Seem to be about there now. Welcome everyone to this session, What Lies Ahead? Health Data Research Beyond the Pandemic. So I'm Simon Ball, I'm Director of the Better Care Programme at HDI UK and a Chief Medical Officer in Birmingham. As you'll have seen and chosen, we have four excellent speakers who will cover some, I think, of what lies ahead, from managing COVID-19 and its complications to how we understand and I think manage the process of recovery for other clinical pathways. I think there's no doubt that we'll need to change the way in which we deliver healthcare over the next 12 months, 24 months, etc. Now more than ever, I think it's fair to say that efficiency also means timeliness and better outcome for our patients. So this is about changing the way in which care is delivered. And whilst this is an opportunity, I think we also must recognise that it's a potential risk. Martin Landry, I think earlier on this morning, mentioned that arbitrary use of unproven treatments is damaging to patient care and public health. Well, I think probably we could say the same applies to healthcare policy and practice in general. So I think in these difficult circumstances, including a very significant residual demand for care unrelated to COVID-19, there's often a temptation to buy into apparently good ideas with relatively little evidence. I think this is where insights from data can and must inform clinical decision-making and policy development, as well as, of course, providing meaningful information to patients around the choices they make about their treatment, which I think will be different over the next 12 months and beyond than they were 2 years ago, for example. And on that note, I'd like to invite Kathy Sudlow, my colleague and friend, Director of the BHF Data Science Centre, and of course, Professor of Neurology and Clinical Epidemiology at the University of Edinburgh. Kathy, can I ask you to lead off?
Indeed, many thanks, Simon. Can I just check that you and everyone else can see my slides?
I can.
Super. So thanks for the opportunity to speak to you about a new health data asset to improve COVID-19 outcomes. So at the start of the pandemic, we and others were aware that there was provision in Scotland and in Wales for linking together population-wide health data assets and for making those available within trusted research environments so that researchers could conduct research on the entire population, which is really important for a number of different types of research questions, not least for addressing the impact of COVID-19 on cardiovascular and indeed a whole range of other diseases. But there wasn't provision for that in either England or Northern Ireland. And so we set about working with NHS Digital to set up their now established Trusted Research Environment Service to put in place what was needed for England and to enable access to a large consortium of researchers to perform analyses within the environments in England, Scotland and Wales, and in the very near future, Northern Ireland. So I'm showing you here what has been a creation over several months, working very closely with NHS Digital, this new environment for England and the data sets that populated. So this environment now contains linked person-level records which include COVID-19 laboratory and vaccination data, hospital data, death registry data, primary care data, the GP data for pandemic planning and research, community dispensing data, and a subset of hospital e-prescribing data. And then a number of additional specialist data sets are also being included, so cardiovascular data assets and intensive care data. All of these linked together, and with the exception of the hospital e-prescribing data, represent virtually the entire population of England. So these cover more than 54 million people who were alive at the beginning of January 2020, which is 96% of the population. This is important because it enables statistically powerful research. It's because of the range of different healthcare sources, it enables comprehensive information on people's characteristics and their health outcomes to be captured. And it's inclusive across all age groups, ethnicities, geographic locations, socioeconomic health and personal characteristics. So very similar setups are available in Scotland and in Wales, and forthcoming in Northern Ireland. So currently the coverage for these linked population-wide data assets is in excess of 65 million people. And the consortium that we have enabled access to these data for currently has over 180 members with very diverse skill sets and specialist inputs, representing more than 40 NHS and academic organisations. Of those, around about 50 or so are analysts who are working now with data in these trusted research environments. And this has enabled a number of projects, with more being added all the time. The consortium works in a very transparent manner so that all of our protocols and code and algorithms are put into the public domain using our GitHub organization, as well as through open access reports and publications. So we have a number of projects. Some of them are methodological. We found out that that data management, curation and analytic pipelines, when one's handling such enormous quantities of data with literally billions of rows of data, are incredibly important, as are high throughput phenotyping approaches. And the ability to share these and make them available for reuse is also incredibly important. We've had a number of medicines related projects which are being conducted currently, and some of which are starting to report. And then a range of other projects looking at the direct and indirect impacts of COVID-19 or on a range of different conditions, with an initial focus on cardiovascular conditions. One in particular, just to illustrate the use of these data, which I want to tell you a little bit about, which is looking at the relationship between COVID-19 and specifically now COVID-19 vaccination and the risk of thrombotic events. So you'll be aware that around about the end of February, early March, reports started to emerge of thromboses in unusual locations, usually associated with thrombocytopenia, and thought to be linked to COVID-19 vaccination, specifically the Oxford AstraZeneca vaccine. So to shed light on who was affected, the size of the risk, and how it would relate to the balance of risks and benefits of vaccination and which vaccines were affected, we have been conducting analyses at some pace on all 46 million adults whose data are included in the English NHS digital trusted research environment, with a multi-institutional interdisciplinary research team. Following the entire population from the 8th of December, when the vaccine campaign started in the UK, through to the middle of March, beyond which we think there'll be significant ascertainment bias, which might change the relative risks. And so we have looked in the first instance up to the middle of March, splitting exposure of the population into pre and post vaccination, and adjusting our analyses for a very wide range of confounders. So this is one good example of where evaluating rare adverse events needs a very large study population, and a really good example of the use of these population-wide linked healthcare data. Also illustrating the need for collaborative team science. This could not have been done by one group or even one institution alone. In terms of the results I've shown you, despite adjusting for many confounders, there's highly likely to be some residual confounding, but the observed increased risk of rare thrombotic events in younger individuals.
Kathy, I think you've just gone on mute.
Oh, apologies, just at the end there. Well, you can read my results, and this is my last slide. So just want to emphasize that these events are very rare, and so the absolute increase in risk is very small. Thank you.
Kathy, thank you very much. That's the beautiful data. If I could just remind everyone to use the Q&A function, and if someone would like to actually put something in any case, it would reassure me that my Q&A function is actually working. And then in the meantime, I will move on to Richard Holtz, who's Nuffield Professor of Primary Care in Oxford, previously, many years ago, of the parish that I'm sitting in right now. But over to you, Richard.
Thank you very much, Simon, and thank you for the invitation to speak at this conference, and well done, Kathy, excellent presentation. And I only hope I do as much credit to principle as you did for the TRE, very sharp foundation. So Principle is basically the UPH Urgent Public Health platform trial for repurposed medicines that may be effective against COVID in the community setting. The rationale for it was that right early on in the pandemic, we realized that there may be some medications which would work early on in the disease, which might not work so effectively once patients had differentiated into more severe syndrome, and therefore was complementary to the other two national platforms, that of Recovery, which was within patients admitted to hospital, and REMAP-CAP, which was based on patients admitted to ICU. And so we have that suite of potential target populations with the UK platform trials. It was actually quite a difficult trial to initiate in the UK because, as you will recall, in the early days of COVID, the NHS was in some disarray, particularly in primary care, where lack of availability of PPE meant that there was an incredibly rapid swap to Principle contacts being digital, and there was quite a lot of illness in primary care populations. So the usual way we'd have run this study, which would have been to recruit patients presenting with acute illness with their practices, was still a route for Principle, but couldn't be the only route, and therefore became a direct to patient potential entry as well. We looked initially at patients who were a priori more likely to have severe outcomes, and that was, as you can see here, patients over 65 or patients over the age of 50 with some significant comorbidities in terms of long-term conditions. We also wanted a platform trial because we set it up so that there would be regular reviews of the data that was coming in from the studies, and that would enable an independent statistical analysis committee to effectively recommend whether the predefined stop rules have been met in terms of early superiority or futility. And it also enabled us to add treatment arms as the evidence for potential new interventions became available. And rather like Recovery, it was an incredibly rapidly scaled trial. And in fact, we had the first recruit in just under 3 weeks after we finalized the protocol. The platform has evolved. We now, as we have started to introduce antivirals, have widened the potential participation into the trial, and we basically now will include anybody over the age of 65. They need no other factors other than COVID infection to be entered. But we now have widened the participation to adults over 18 who have either significant comorbidity or who have become short of breath in association with their COVID-19. And all of these drugs, it's not a placebo-controlled design, it is controlled against usual care. The primary initially that we were looking at was based on the data from China, which had a much higher rate of hospitalization and death. And in fact, it subsequently transpired that in some countries, patients were automatically admitted to hospital if they developed COVID. And those data, therefore, that we were basing our initial power calculations on, were much higher rates of hospitalization than that observed in the UK. And we therefore did a change to our co-primary. This was prior to actually us running any of the arms reaching either futility or superiority. We changed to a combined endpoint of either earlier recovery, time to self-reported recovery within 28 days, or hospitalization and or death. And as I said, as things evolved, we have defined the primary analysis to be the COVID positive population. Early on in the trial, we couldn't do that, and I'll show you a slide in a second, simply because access to testing was such that only a relatively small proportion of the population could determine that, and therefore in the early months of the trial, it was COVID syndrome that we were testing rather than COVID positivity. But as testing became more widely available, we have altered the primary analysis to be based on COVID positive patients, but obviously we are doing secondary analysis on total population. Those are practices that have recruited at least one participant to principal, so it is a truly multi-country, cross-UK trial. And here is the data just illustrating this point. In orange there are patients who have confirmed COVID. You can see that towards the autumn, the majority of patients entering the trial actually were able to get a confirmed diagnosis, but early on in these months, hardly any patient could get a confirmatory test done in the community. These are the arms that we've currently looked at. The hydroxychloroquine was the first arm we introduced. That was actually stopped by the MHRA because of a flawed observational study that reported. We didn't restart that trial despite the withdrawal of those data, simply because the population were no longer in equipoise about hydroxychloroquine, and we had feedback that practices would have been reluctant to randomize into that arm. We have, though, stopped two antibiotic arms. They were stopped because of futility, and the azithromycin arm has been published, and the doxycycline arm is in press currently, both showing no benefit, which was a really important finding, because actually increasing numbers of patients in the UK and many other parts of the world were defaulting to adding an antibiotic, these particular antibiotics, in all their patients presenting with COVID. We stopped the budesonide arm at the end of March, oral inhaled budesonide, and the reason for that was because of superiority, and that was reported in an interim analysis that I'll show you in a minute, and we have now finalized the analysis, and it is currently submitted for publication. The colchicine arm was stopped shortly after that, and that was actually based on futility, but the favipiravir arm continues, and we've actually just added an ivermectin arm today. So after the azithromycin and doxycycline arms, a therapeutic alert went out from the NHS, and as I say, the budesonide arm was stopped because of superiority. You can see here basically a mean 20% improvement in terms of time to recovery, which actually translated to about a 3-day benefit to patients, and a trend for lower hospitalizations in all arms, reaching significance in the concurrent COVID positive arm. And indeed, these budesonide data showing the separation between that and usual care occurring at about 7 days. That has already resulted in an alert, and NICE are waiting for our final data before making pronouncements on oral budesonide and whether it may become standard of care. We have had support from HDR UK in this. It became clear early on that the practices were finding it difficult responding to our need to double check patient safety in terms of their eligibility to enter the trial. And what we've managed to do with NHS Digital, supported by HDR UK, is speed up access to the test and trace, so that we actually get access to patients testing positive and are therefore able to contact them earlier, because obviously the earlier we can initiate treatments, the better. And we're also trying to reduce the bottlenecks that were occurring in terms of ascertaining endpoints in terms of access to the routine record. And I'll end just by saying thank you very much to obviously all the patients who have thus far taken part in Principle, and to the many practices that have contributed data, and indeed to the many other partner organisations that have contributed to these results. We also continue to provide the national surveillance within the community for COVID. That's based on linked data sets within Sentinel practices in the UK. That is ongoing. But we hope that it'll become an even more efficient trial in terms of digital linkages downstream. Thank you very much.
Thank you very much, Richard. And as I say, we'll come back to questions at the end. So 2 fantastic talks there. I'll now turn to Colin McConnell, who's Professor in Health Data Science at St Andrews and an Associate Director for HDI UK in Scotland. So Colin, over to you.
Okay, so thank you, Simon. So I'm Colin McConnell, I'm based at the University of St Andrews. I'm going to speak about 2 studies I'm involved with. One, the HDI UK Multimorbidity Implementation Project that I lead with Ronan Lyons, based at the University of Swansea. And the second is the EVE2 project led by Professor Aziz Sheikh at the University of Edinburgh, which is where we have done some work relating to COVID-19. So I'm going to go through my talk by giving you some background to the Multimorbidity project. I'm not going to give you any background to the pandemic, because unfortunately we're all too aware of what's been happening over the last 18 months. But I thought I would give you some background to what we've done in the Multimorbidity project. I'm then going to explain how we've used that in our COVID-19 research. And I'm then going to sort of look across the 2 projects and talk about what I think are the important things coming from that we need to be aware of going forward. So to give you an idea of the project, we basically had 4 different work packages. So at the bottom of it all, and sort of contributed to it all, was our public and patient involvement. And that was led by Sophie Staniszewska at the University of Warwick. We recruited a panel from across the UK, and what we've been doing is, for each of the work packages, we presented our plans to them. We've had feedback from them. We've integrated that into our plans. And what we're now doing is we're taking back our findings to get them to help us interpret and also to inform them of those findings. The second piece of work we had was a conceptualization work. So this, we published yesterday in Lancet Public Health, a review of measuring multimorbidity using electronic health records. And the review had 566 studies in it. So one of the difficulties with multimorbidity is it means many things to many people. And if you're not clear about what you're looking at, it's very difficult to get comparable results. So Bruce Guthrie at the University of Edinburgh has been leading on this work. And what we've been looking to do is to try and be clear and understand what we actually mean and be consistent on how we treat multimorbidity. Both of these work packages have fed into what we've done then in the other 2 pieces of work. We had 6 different data sites, each of whom were asked to identify a cohort of people who were aged 25 plus at the turn of the century. They were then asked to follow those people up and extract data on them over the next 20 years. What that's allowed us to do is we have a cohort of 4.2 million people in Scotland and a cohort of, I think it's 2.3 million people in Wales. We also have data at QMUL on a smaller group of people, and we've data at Calibre within UCL on a larger group of people. What we've asked each of the sites to do is to extract all the diagnostic information relating to conditions of interest and create research-ready tables in a standardized way so that the analysts can simply get on with the work they want to do. We have 7 different institutions providing analysts, and what they're doing is they're looking at a body of work around clustering of conditions and also then looking at trajectories of conditions. And the approach we've taken is very much a team science approach. So they're all working together, but what we're asking them to do is, as they develop code against one data set, they're then having to pick up that code, move it, run it against a different data set with some of the analysts from different sites, to ensure that what they're doing is replicable and it's also robust. And also then it's a way of us learning from the expertise of others. So we've got machine learning experts, we've got statistical experts. And what we're trying to do is share that learning and learn together throughout the project. So what I'm going to now do is then talk about two pieces of work we've used the findings from our multimorbidity project relating to COVID-19. So this first piece of work was based on just under 4,700 people who were admitted to hospital in Scotland during February and September last year. And what we did with these individuals was we looked at the electronic health records we had on them, and we identified their level of multimorbidity using something called the Elixir index. Now it records, I think it's 32 conditions. And what we were able to do was look at to see whether each of these individuals had these conditions. And we were then interested in the proportion of multimorbidity in the patients being admitted. And you can see from the graph on the left-hand side, overall, about 60% of patients who were admitted with COVID-19 had multimorbidity. The second measure we were interested in was this idea of complex multimorbidity, which is 4+ conditions. And again, you can see that there's a strong relationship with age. So as people got older, they were more likely to have multimorbidity, and a much higher proportion of them had complex multimorbidity. What we've done with this analysis, which is currently submitted for publication, was we then related that to the risk of mortality. And again, the graph on the right, you can see how multimorbidity and complex multimorbidity increased the risk of mortality in these groups of patients. We also had information on whether the individual patients were on the shielded patient list. So whether these were patients who'd been advised to shield at home because of the high risk of complications if they caught COVID-19. And what we found was that multimorbidity was still an independent risk factor after allowing for shielding status. We investigated whether it was there was an interaction between multimorbidity and the shielded patient list patients, but what we found was it was just an additive effect. It wasn't multiplicative. So the second piece of work we then did was based on the EVE2 cohort. Now, Aziz Sheikh spoke about this morning, but it's basically everybody in Scotland, and we're monitoring what happens to everybody in Scotland, and we're able to identify in reasonably near real time outcomes for these patients. So we were interested in what happened to people after their first vaccination or their second vaccination. Specifically, we were interested in trying to identify how many people had serious adverse event. And by that, we meant either COVID-19 hospitalization or death after being vaccinated. And you can see again, what we did here was we used the Q-COVID risk groups that Julia Hipsley-Cox described this morning when she was talking about the Q-COVID risk calculator. So for each of the individuals in this study, we were able to identify, did they have one of these individual conditions? And again, what we looked at was how many of these conditions we could have, or sorry, the patients had. So again, you see in the bottom left-hand corner, the idea of the more conditions that you have, the more likely you were to suffer an adverse event. And again, on the right-hand side, that just the adjusted risk ratios for this. So the rate, off the top of my head, it was about 6 admissions per 10,000 patient years. So again, it's that idea of we're talking about an increase in risk, but it's a relatively small risk of the event of interest. Okay, so that's basically what I'm going to say. So what have I drawn from this and what do I think is important for us going forward? So I've picked them 3 items. Again, I've picked these 3 items before hearing anybody else's speech today, although I feel like I'm just echoing what other people have already said. The first thing I would flag up is about the data. So when we talked about what we wanted to do with the multimorbidity work, we got criticized quite a lot because at the 6 different sites, we had different data sets. So some of the data sets were secondary care data. Some of the data sets were primary care data. Some of the data sets were a mix of primary and secondary care data. But the approach we took was let's be transparent on how we're doing this. Let's standardize what we're doing so that we're trying to identify exactly the same thing in each of the data sets. And what that allows us to do is when we see there's a difference between the results in the data sets, we can start to explore and find out whether it's about the underlying data or whether it is actually about the underlying population. And I think that same thing has come through very much in the COVID pandemic. There's no such thing as an ideal data set. So what you've got to do is you've got to find a good source of data, you've got to understand it, and you've got to make use of it as best you can, but be transparent in its use. The second thing that I wanted to flag up was about how we identify conditions. And again, the approach we took in the multimorbidity study was to use phenotypes. What we found was that there were phenotypes for specific data sets. So I talked about Alzheimer's, which is 30-odd conditions. We were able to combine phenotypes for primary care, secondary care, and then that allowed us to sort of say, is this the same condition across both those data sets, and are we looking at the same types of patients? And more importantly, we were able to explore this. And I think it's hugely important that we all start thinking about how we use the HDR UK genomics work, because again, in the COVID pandemic, what we found is we're interested in particular conditions. So we had the safety scars around ITP and things like that. One of the challenges we had was how do you identify ITP in read code data from general practice? How do you identify ITP in ICD-10 code data from hospital sources? So we need to start using phenotypes, and we need to start making sure that we're looking at the same things. And the last thing, again, it's been flagged, I think, in virtually every talk I've heard, but it really is about team science. So we were really fortunate in that what we were able to do was we built a team for the multimorbidity work. Within Wales, that team actually got repurposed and started doing their national reporting on the what was happening in the population in the pandemic, using the skills they'd found from the work from Multimorbidity. What we were able to do was we were able to join Aziz's team, which was set up initially to service the HDR UK Breathe data hub. So what we were able to do is we were able to pull together teams, and we were able to work collaboratively. We were able to bring skills, and we were able to learn from each other. And I think that's a key thing we should be taking from this pandemic. It's how do we make that easier to do, because it's not easy to do, but it's really important if we're actually going to find out how to actually sort.
Colin, I think you've gone on mute as well. Colin, have you finished? You just went on mute just before the end there, so. In that case, I'm going to assume that you finished. Thanks.
Yeah, I'll finish now, Simon. Sorry about that.
Thanks very much. Okay. So, Colin, thanks very much. We're going to move swiftly on to Ben Johnson, who's well known to us as lay member of the HDR UK Science and Infrastructure Delivery Group, and Ben works as head of communities and engagement at Springer Nature. So, Ben, over to you with no slides. Very teaching us a thing or two.
Brave or foolish. Thank you so much for the invitation to speak, and also for the excellent previous talks. My role here is as the so-called public contributor, and I see my goal as posing some challenges for the use of health data in the future. As Simon indicated, I'm a lay member on the HDR UK Science and Infrastructure Committee. I have a slightly odd position because I'm an ex-scientist. I trained as a virologist at Public Health England, and then Imperial College London, but then became an engagement professional. And actually, since this year, I've been an editor at Nature Medicine, a scientific journal. And so I have a great privilege of reading a lot of what the world's top scientific minds are thinking. Many of whom are speaking at this conference. And it's clear that there's a huge excitement about the potential for health data research in the future. But I also see the potential for an unequal future where some have access to this and others do not. And it's clear that there are existing inequalities, huge inequalities within countries and between countries that have been highlighted so clearly by COVID. Some of the data presented today by the ONS showing that mortality rates in the most deprived parts of England are much higher than in the least deprived parts of England. Similarly, very worryingly, in-hospital mortality rates differ by ethnic group, with much higher fatality rates in some ethnic groups. And globally, the differences are as stark or more stark between different countries. There is a huge global health inequality that COVID has highlighted. And really, COVID-19 is an infectious disease of poverty. the COVID pandemic is currently raging in Brazil and India. The vaccine that I received from Oxford AstraZeneca was tested in Brazil with Brazilian volunteers, and may well have been produced in India at the Serum Institute. And yet in Brazil and India, it's now extremely hard to get hold of that vaccine. Contractual obligations have not been met. And we now have new variants of the virus emerging in places like Brazil and India because of a global failure to provide access to the vaccine. And it does look to a lot of us that there's one rule for the wealthy and another for the poor. To take just a specific example, thinking of kind of digital medicine, low blood oxygen is a key predictor of severe COVID. If you'd like to measure your blood oxygen at home, using some kind of new technology or a mobile phone app, there are a few barriers in the way of that. You need a smartphone, which can access the internet. You need reliable internet connection. You need some kind of mobile blood oximeter that maybe you can buy from Amazon. But you also need for this technology to work on people like you. It's known that blood oximeters are less effective on darker skin. This is published in the New England Journal of Medicine. It's totally unacceptable to have this kind of defect that doesn't work on everybody for this essential medical device. Digital exclusion is a huge issue. It exists in the UK, where I live in South London. There are a lot of people who do not have reliable access to the internet. If you look more widely in the world, it's obviously an even greater problem. This is a huge problem again, if you're trying to develop new technologies, a lot of which are made by tech companies like Google. If you look obviously in places like India, maybe a quarter of people have a smartphone there. In sub-Saharan Africa, internet access has hugely increased over the last 5 years, but still just a quarter of the population have reliable access to the internet. And so just taking one example of health apps, they're made using everybody's health data, but some people are not able to see the benefit. And so if you're using people's health data, those people have to be able to benefit. It's a particular problem when you look at genetic sequencing, and this was covered in one of the plenaries. Still, the vast majority of sequence data is from people of European ancestry. If you're doing something like a polygenic risk score for your prediction of risk of cancer, they simply will not be accurate on a large amount of the world's population. And so you have to ask yourself, or I ask myself, why should underrepresented groups consent to their health data being used when they may not benefit? Now, there's a chicken and egg here, obviously. The more diverse, the more you can involve people from different backgrounds in health data research, then the better the data gets, the more it benefits them. And so you need to find a way of turning that vicious circle on its head, particularly when you're looking at some communities where there is a very good reason for distrust of medical professions and distrust of use of data. If you consider, for example, the African American community in the US, the LGBTQ+ community. And so how do we tackle this? I think you clearly need tech companies, because a lot of this comes down to technology companies in the end. These medical, the use of data, the implementation of this data. You need more diversity there. You know, Google is not a diverse company. Only, for example, a third of the Google employees are women. And you see a lot of apps that do not serve half the population. Well, you need to sequence more genomes, of course, from the world's population. You also need to involve patients and public participants in the group. And there was an excellent session earlier, which I hope you all saw, on PPIE. And you also need to involve the public in discussions about access to health data, which is so critical for trust. And there's obviously a lot of discussion around this globally. And at the moment, this emergency use of health data during a public health emergency, should this carry on? Do we need a national discussion, or should access to that data stop? And for me, I think it's important to look at what that data is being used for, and perhaps a bit of creative thinking in allowing flexibility for the user, for the patient, for the member of the public. Do I want my data accessed by my medical professional? Would I like to access it myself? You know, I think that there shouldn't be any system where the data can be used by researchers or by commercial companies where the patient themselves can't access the data. And I think data access by researchers is so important, and we've seen that through the talks in this session, and all of today has been about data access by researchers. But if an individual person does not want to share their data, then you need a conversation with those people, but also accept some people may choose to opt out. And what you may see, like they've seen in Iceland with ENCODE, is a gradual increase as more and more benefits are shown. I think consent and involvement are needed for trust. We need more engagement and involvement with underrepresented groups so that they will opt in to use of their health data. And I think, to end on a more positive note, I think there are some studies, there is some cases where health data can help level the playing field. And I think it has a huge potential to document health inequalities, to erase health inequalities. But for trust in the use of health data within a pandemic or without, it has to be used for those people's benefit and with their consent. So I'll leave it at there, but I hope that's a useful kickoff for our discussion. Thank you.
Thanks very much, Ben. And yeah, no, I think this use of data for democratization is a really important point. Again, please do enter your questions into the Q&A section. But if I could perhaps first of all turn perhaps to Richard and ask specifically around this question around how do we best engage the patient voice in the types of studies that you've just described, and how do we actually specifically address this question around health data poverty, I suppose?
Yeah, no, I mean, I think really what we definitely want to do from our experience with COVID is learn about the things that worked. And I think Ben has illustrated how if people get some direct gain from involvement, then they're more likely, understandably, they're more likely to engage in processes. And I think that's going to be a challenge for us, is how can the indirect gain they will get from contributing to a study like Principle actually benefit them more tangibly? Because of course, if you're in a randomized controlled trial and you agree to take part in it, half of the people aren't going to get anything different than usual, and the other half may or may not get a benefit. So it's a pretty utilitarian reason to take part. And this engagement with the public, where they get the opportunity to talk to researchers about why they might take part in a study, I think is really critical. And it's been unusual for us to have quite as much discussion with patients as a research team, because normally that is sort of indirect through the patient's own practitioners. So that's been a really quite interesting experience for us, and how we can articulate the sorts of concerns that individuals express when they're considering whether to take part in something. I think we've got to get smarter about that. How we provide information before we speak to people, what information is provided during the consenting procedure, and indeed subsequently, since what we want is to gather as much data as possible, because it'll produce a more reliable result. And of course, that impinges on patients' lives. I mean, I think this question about equity is a really important one. It's for Principle, although we could argue that the representation is reasonably representative of the UK, that does mean that we have low rates of ethnic minority patients in the trial, which is a problem for us. So I think it would be good to have time to reflect on what have been the positive and negative experiences around use of data, use of team science, the relationship between researchers and the general public, and actually start to engineer a better environment for all of us post-COVID.
Yeah, no, thanks, Richard. It's something we're very conscious of in our own city, the city I'm sitting in at the moment, Birmingham, where there is such a diversity of ethnicity and indeed poverty. And we see that in terms of primary versus secondary care recruitment, for example. Can I just quickly turn, I'm conscious of time, to Kathy and then to Colin around looking at the use of the methodologies that you've described to look at the non-COVID related consequences or indirect consequences in non-COVID illnesses over the course of the last 12 months, but perhaps the 12 months to come and beyond. Kathy, can I perhaps start with you around how we might start to understand where we prioritize investment, I suppose, in terms of addressing the backlog and the recovery from the pandemic?
Yeah, it's a really good question, Simon. So as you allude to, COVID-19 has direct impacts across multiple different conditions and areas of mental and physical health, but also has had indirect health impacts as a consequence of system disruption. And both of those can be interrogated using population-wide linked healthcare data sets from secondary healthcare and primary healthcare. And we've seen already the kind of substantial reductions in presentations to hospital with acute cardiovascular conditions, increased waiting times, and reductions in administration of therapy for cancer, reductions in appointments and services for people with mental health conditions and so on. We've seen it in the data and we've heard it anecdotally. So the advantage of these linked population healthcare systems is that you can systematically look at that across the whole spectrum of conditions and do exactly what you've suggested, which is to look at what's going on and prioritize and plan for the future. The NHS itself has been doing some of this because on the other side of the firewall, outside of the world of trusted research environments, the same sort of data sets can be accessed by those who are directly looking at healthcare policy. But I think it's particularly useful to have researchers help in that, because we can often provide independent and different analytic views and do things sometimes in a more sophisticated way. It's very interesting working with, for example, colleagues in NHS Digital that hadn't really thought about linking across all of these different healthcare data assets before to get a unified view, because they're used to doing things based on one data set at a time. So I think there's huge value in what you suggest, and I would say we're currently probably only scratching the surface in terms of really unearthing that value.
Before I turn to Richard, can I just, absolutely, and I think that scientific rigor is hugely important, because there's such a temptation. I worked most of my life in the NHS to buy into the solution that's presented, and it's not always it's not always well evidenced, as I alluded to earlier. Colin, can I just ask you to just touch on the question of that group with multiple morbidities and looking forward to next winter and what have you? What might we be able to tell about these groups?
So I think we've been looking at epidemiology, for want of a better phrase. So we're trying to think about how are people affected, what's happening to them. But as you said, Simon, what we need to think about is how do we actually sort of deliver a difference to the lives that people have and the treatment they get. And we're going to try and push on with that. I think one of the things we've been very keen on with the story we've had from how does multimorbidity impact survival from COVID-19 is to see whether we can think about, do we need to get a broader message out there? So I think Julia spoke this morning about how the work with Q-COVID had led to a rebranding of the shielded patient list and an additional 2 million patients who were identified as people who should actually be shielding because they were at high risk of disease. And the work we've been looking at would suggest, well, we think people who are highly multimorbid are probably in exactly the same boat, but may not yet still make it into the shielded patient list. Now, we've not done our analysis specifically to look at that, but I think it's something we need to think about going forward. And it's that thing, we didn't include, or we've not included COVID-19 as one of the multimorbid conditions we're interested in. But I think going forward from now on, that seems ludicrous, because it's going to have such an impact on everything about how individuals and about how healthcare systems work in the next, well, I don't know, I'm not a clinician, but I would say definitely for the foreseeable future.
Until I retire, that's for sure. Yeah, no, absolutely, and beyond. So, Richard, you had your hand up. Do you want to just come in quickly, and then I'll turn to Ben?
It was just a specific point on this, because I mean, we've been looking at the sort of recovery in practices, and we're looking at how practices were dealing with alarm symptoms in relation to 2-week referrals. And interestingly, it looks as if by September, practices had pretty much got back to as you'd expect them to be. If an alarm symptom presented, they were referring these patients within the 2-week wait cycles. And the explanation for this huge drop was patients clearly were not presenting with symptoms. Now, that's a mega problem for the NHS if we've basically advised patients to not use the routine NHS because of concerns about COVID and spreading the risk, etc. Which means, coming back to Ben's point, we need a complete re-education now of how the public should be using the services that we provide to actually do what you're much more likely to be dying from stroke and heart disease than you are COVID, even during the COVID pandemic. So we've got to address that balance. And we also have got to get across these really complex questions that Kathleen illustrated, which is a doubling risk of an incredibly rare, i.e. a very, very low absolute risk, is a tiny risk. And yet that is already affecting people's perceptions around the world around the safety of vaccines, particularly in countries like Japan, for example, where vaccine hesitancy is as high as 60%. And it's same in the US. You know, this is going to be a mega problem for health systems if we don't get better at how science can both identify the issues, but then better communicate with people really what that means in a way that they trust.
Good. I'm getting messages pointing out the plenary starts in 5 minutes. I'm going to let Ben have the final word.
Oh my goodness, how do I follow that? I just, I think it's a really positive session. And I think what's great about HDI UK as a plug for the organization is a lot of PPIE has dropped or been cancelled during the pandemic. And I think that that's not the case for people here. You know, it can be done quick, it can be done nimbly, and it's not just the ethical and right thing to do, but it improves your research. So well done to all those who have involved patients. There's no excuse for not doing it.
So very many thanks to the speakers, to the attendees for today, and to the speakers earlier today. It's the parts of the meeting that I've got to have looked absolutely fantastic. So much appreciated. Thank you. Stay well.